First, it is against Quora terms of service to use a fake name. I suppose your mother decided that Let was a good name. I'll let it go this time. Diabetes mellitus comes in types 1, 2 and 3. All of these are marked by higher than normal blood glucose levels, hyperglycemia. Low blood glucose, hypoglycemia, in diabetics is often caused by drugs. For those injecting insulin too much or not eating enough after injecting results in hypoglycemia. For those using oral and/or injected drugs to stimulate natural insulin production and sensitivity, hypoglycemia as a risk. Many T2DMs experienced reactive hypoglycemia before developing diabetes. Around 3 hours after eating, the person's blood glucose will drop below normal. This is a sign that the person's body is not controlling BG correctly. Even without eating, there is loads of glucose stored in the liver. Both, and neither. The issue is your use of the term, diabetes. There are 7 totally different diseases called diabetes, in 2 large groups. D. Diabetes insipidus, and DM. Diabetes mellitus. Others have responded correctly, but I thought I'd provide an outline to encompass it all. D is a group of 4 different diseases that are very rare, but not uncommon. They all involve a lack of, or poor storage of, or poor response to, or any combo of those, the hormone vasopressin, aka ADH, antidiuretic hormone. ADH is the hormone that regulates body fluids. It essentially turns off the kidneys, preventing you from urinating. Vasopressin has nothing to do with BG, blood glucose, levels, so in these patients, BG is neither high nor low. But when vasopressin is lacking, or not released properly, or the kidneys don't respond to it properly, you don't stop urinating, which dehydrates you. As a result, you suffer polyuria, excessive urination, and polydipsia, excessive unquenchable thirst. Those are the same primary symptoms of DM, which is a group of 3 different diseases that are very common, and all involve a lack of, or poor response to the hormone insulin. Insulin is one of 6 glucoregulatory hormones that control BG levels, but it is the primary BG-lowering hormone. The others all either raise or lower BG, but the primary counter-regulatory hormone to insulin is glucagon, which raises BG. When insulin is lacking, or ineffective, too much glucose gets left behind in the bloodstream, and not enough gets into the cells of the body, all of which need glucose to live. Diabetes, by the way, means siphon in ancient Greek. It's a reference to the constant urination and thirst of all of these patients. The ancient Greek physician, Apollonius of Memphis, coined the term around 250 BCE. Later, in 1675 CE, the English physician, Thomas Willis, added the secondary terms. Mellitus is Latin for sweet, and insipidus is Latin for insipid. These terms refer to the urine of these patients. DM patients excrete a lot of glucose, sugar, in their urine, while D patients urinate so fast that their urine is insipid, clear, odorless and tasteless. So, you're interested in the 3 types of DM. Here's a little outline. T1, or type 1 German mark, is an autoimmune disease wherein our immune system completely destroys the insulin-producing cells of the pancreas, leaving us with no insulin at all. Without insulin, the fuel our cells need, glucose, cannot get out of the bloodstream, the body's delivery system, and into those cells, so they starve. The body fuels itself with ketones, derived by burning off fat tissue, and after that is gone, muscle tissue. Without injected insulin, T1s die of ketoacidosis, a condition induced by excessive burning of fat and muscle tissue after wasting away, and losing the ability to function and think clearly. So the primary issue is elevated BG levels, but insulin use can cause rapid BG reduction, and lead to hypos, or hypoglycemia, low BG. Once we begin treatment with insulin, which is the only treatment that works, we are always at risk for hypos. Insulin is a harsh mistress. The life she gives, she'll take away in an instant. The dose that worked fine all last month may be too much or too little today. It's a fine line determining what's right, and how much to use. We must take a daily basal dose, and mealtime doses for all meals. Various circumstances affect our insulin sensitivity levels. Having a cold or any infection will make us less insulin sensitive. Severe temperature changes, circumstances can affect our sensitivity. Even elevation can affect it. In any event, we T1s are subject to lows for no apparent reason, though many are apparent: failing to eat on time after dosing for the meal, eating too little for the dose, extending an activity session beyond what was planned for, and so on.